This is a really very exciting meeting and a very exciting time in scleroderma. And one of the reasons is I have all these disclosures. Years ago, we didn't have a lot of involvement with industry, and almost every month I have a new company say, oh, we want to do research in scleroderma. So I'm today going to talk about the lung and really focus on the two major lung problems, pulmonary hypertension and pulmonary fibrosis. And what I hope to do is to show you how you can identify whether you're at high risk for these problems and know what you need to do about that, and describe all the exciting treatments that are available now. So years ago, I was involved with the Pittsburgh Scleroderma database and spent half of my career anyway, collecting lots of patients and information on what happened to them and why they died. And this is a series over a 30-year time period from before I got to Pittsburgh to almost the time that I left. And when I first started in this disease, renal crisis, which is the red bar, was really the major cause of why people died. And then in the 80s, we had this new hypertension drug, an ACE inhibitor. Had nothing to do with scleroderma, but we identified that it really treated renal crisis. And then over the next 30 years, it became very clear that the main reason why people were dying of scleroderma were pulmonary fibrosis and pulmonary hypertension. And when you look at all causes of why people die, more than half of people die with scleroderma die of other causes, not scleroderma related. But if they do die of scleroderma, half of them die of pulmonary hypertension and pulmonary fibrosis. So this has really been a big focus on research and what's going on. So we're going to talk about lung disease, and it has many, many symptoms, and it can be very challenging to try to figure out whether the symptoms you have are from lung disease. So the biggest symptom is that you get short of breath when you exercise, but fatigue, just having fatigue when you exercise may be a symptom. You may have some chest pain, you may have cough, you may get so lightheaded you almost faint. You can have swelling in your legs, which can be a sign of heart failure. Or you can get low oxygen and get more digital ulcers. So it really has a wide spectrum of symptoms and sometimes can be very hard to diagnose. And it's important for you as patients to really pay attention to this. Particularly, we're interested in how much activity you can do with exercise. And what happens, I think, is that a lot of patients sort of tend to adapt to their shortness of breath. They may deny that they have any shortness of breath. I remember one of my first patients with pulmonary hypertension that I tried to talk into getting this new medication about 15 years ago, and she said, oh, no, I don't have shortness of breath. I said, I know you have shortness of breath. I gave her the medicine, and she came back 3 months later, and she said, I can go to church now. I haven't been able to climb those stairs for 3 years. And she hadn't even realized how short of breath she had gotten. So I think it's really important that you pay attention to whether you're more fatigued, more tired. Think about whether when you go to see your doctor particularly, so you can share this information with him or her. And think about whether you're able to climb the stairs as rapidly, carry bags. Are you doing as many activities as you used to do? Are you doing them as fast or as often as you did them? And please share that information. As you know, when we see you, we have lots of questions and information to get from you to see how you're doing. And we need your help in interpreting this rather than just saying yes or no. So we're going to start with pulmonary hypertension. And this is just a chest x-ray. And generally, the chest x-ray, as far as the lungs are concerned, really don't look too bad. But what it is it's a narrowing of the arteries inside the lung, and then that puts pressure on the right heart. And so this is a normal blood vessel, and if you have increased flow, if you have normal blood vessels, that blood vessel just enlarges or dilates to handle the flow, and it's no problem. But if you have a scleroderma blood vessel in the lung, gets thickened and gets much stiffer, if you increase the blood flow through that, it's much harder to dilate. And so as the blood's trying to push, the heart's trying to push the blood through those vessels, it really has to work harder and compensate to handle that. And so this is the heart, and we have the right side of the heart here and the left side of the heart. And if you start here with the blood vessels being thickened, and normally it goes into the lungs, and then it comes back into the heart, and then goes to the rest of the body. But when you have high blood pressure in the lungs, that blood pressure is very high compared to normal, and that puts this strain on the right side of the heart. And so that's what then causes increased pressure in the heart, or pulmonary arterial hypertension. So what I've spent a lot of my career doing is trying to identify the risk factors so we can identify patients who are at greatest risk for developing it. And these are some of the things that have been identified. So it's not something that usually happens early in the disease. It happens over a much longer period of time. It's uncommon to have it within the first 5 years. It's often in patients that have the disease at an older age when they get the disease. It's more common in limited cutaneous disease than in diffuse cutaneous disease. If you're getting new digital ulcers when you haven't had digital ulcers before, that may be a clue. All those funny little red spots that you have all over, if you have lots and lots of them, that is a clue. And also, something I think is very important are the autoantibodies, these markers that we talk about, that they are really good clues as to whether you're at increased risk. And the ones particularly are the anti-centromere antibody, which is the one that's associated with the limited cutaneous, or what some people still call the CREST syndrome, or an anti-nucleolar pattern ANA. So this is an ANA that has a certain pattern. Like the centromere, it's the nucleolar pattern. And this is an antibody that's more common in African Americans, and thus is a risk factor for pulmonary hypertension as well. And then we have these pulmonary function tests, and I'm sure all of you have done them, where the pulmonary function tech yells at you, more, breathe, breathe, breathe. And these are very helpful in both kinds of lung disease. And so the two ones that we particularly focus on are the forced vital capacity, or the FVC. And this is a measure of how much air you actually can get in your lungs. And so if you have a lot of scar tissue or fibrosis, you can't get as much air in. And so that scarring or fibrosis causes a decrease in the forced vital capacity. The other measure is called the diffusing capacity, or the DLCO, and that measures whether oxygen can diffuse from the air into the bloodstream. And this can be decreased in either fibrosis, or if you have thickened blood vessels like in pulmonary vascular disease. And so one of the features that I found was a risk factor is if this DLCO was less than 60% of predicted. Normal is 80 to 100%, and so if yours is down to around 60%, that is a very good risk factor. Doesn't mean you have it, it's a risk factor. And if you have a ratio of the forced vital capacity, which again is a measure of fibrosis, and most people with pulmonary arterial hypertension don't have a lot of fibrosis, so that part of the ratio is normal, but the DLCO is very low, so it ends up being a ratio of greater than 1.6. So these have been very good clues as to whether you're at increased risk. And so when I did a study years ago, I showed that patients who develop pulmonary arterial hypertension in comparison to similar scleroderma patients, they had a DLCO 5 years before the onset of their pulmonary hypertension that was 52% predicted, lower than 60, and the controls, other scleroderma patients, it was normal. And this ratio, the FVC to DLCO, was 1.87, compared to 1.04. And this, as I said, was 5 to 6 years before they ever were even considered to have pulmonary hypertension. And when we did a study across the US of pulmonary hypertension and scleroderma. There were 20 sites, and we ended up with something like 200 patients with pulmonary arterial hypertension. And we saw when they were diagnosed with pulmonary hypertension, less than 5% of those patients, only these, I'm sorry. Even these, just these patients here had a DLCO that was greater than 70% predicted. So this has turned out to be very helpful. So if you're in this 70 to 100%, then your risk for developing pulmonary arterial hypertension is really pretty normal. It's pretty rare anyway. So the echocardiogram, which is another one of these tests, the sound wave test that everybody should have had, and this is the other test that's a good for screening of whether you actually have pulmonary arterial hypertension. But there are problems with the echo. Sometimes the pulmonary artery pressure, the flow, can't even be seen on the echo. It's only an estimation, and it involves a complicated formula, so that a little bit of error in the technician's measurement of this flow can lead to very high levels that really are falsely high. And then there are other causes of increased pressures. And the important thing is that you can't make an official diagnosis of pulmonary arterial hypertension without actually having the right heart cath. And so this is the gold standard, and this is what has to be done to make the diagnosis of pulmonary arterial hypertension. It can also make sure that the increased pressures or the pulmonary hypertension isn't from a problem in the left side of the heart. So it's really important that it's done. The world has tried to come up with measures on how doctors can screen you for pulmonary hypertension. And the Europeans have a group of tests, particularly a test that's part of the echocardiogram called the peak tricuspid regurgitant velocity. Too hard to say, but anyway, they had a whole bunch of parameters here that if you have this measure, and if it is a certain value and something else happens, then that's the group of patients that should have a right heart cath. And then in the US, we did a study called DETECT, and that was in a group of patients with scleroderma that had a DLCO less than 60, that risk factor, as well as having a little bit longer disease, greater than 3 years. And they had a two-step formula. They collected all these values, the FVC to DLCO ratio, whether you had telangiectasias, whether you had an anti-centromer antibody, a blood test about the heart, a serum uric acid, an EKG, and if you had enough points with all those parameters, then they said, okay, go ahead and do an echocardiogram. And then they had a couple of parameters on the echocardiogram, and if you had those parameters at a certain value, then they said, okay, go ahead and do your right heart cath. The challenge is that with this approach is your doctors don't do all these tests. We don't do EKGs every time we see you. We don't do uric acids every time we see you. And even when we do the echocardiogram, some of these parameters aren't the ones that the echocardiograms refer to us. So it's sometimes hard to use this approach to be confident that we should do the right heart cath. And then the Australian group, who's also very involved with scleroderma, the Australian Scleroderma Interest Group, they had another method. So they used this blood test as well as the PFTs. And so all these complicated formulas are all ways to try to come up with an idea of whether you're at risk for having pulmonary hypertension and whether you need a right heart cath. When they studied all three of these methods, they really were pretty much the same as far as sensitivity, but a lot of them required a lot more extra right heart caths that were normal. So what does this mean for you? I think it's important for each one of you as a patient know whether you're at high risk for pulmonary arterial hypertension. That means you have to have your baseline PFTs. You should know what your DLCO and your FVC to DLCO ratio is. And if you are at high risk, then you need to have these PFTs and the echocardiogram done every year and work with your doctor to determine if you have to have a right heart cath. Because it really is very exciting times. When I first started my research in pulmonary hypertension, we had no treatments for pulmonary hypertension. And now we have many, many treatments. This is just the pathogenesis, where we have these 3 different pathways. Endothelial pathway, which is a very potent drug to dilate the blood vessels. The nitric oxide dilates the blood vessels, and the prostacyclins. All these drugs are to try to dilate the blood vessels. And we now have 14 different therapies that have been used that are being used for the treatment of pulmonary arterial hypertension. This has been a dramatic change over the past 15 years. Now, years ago, when we first started doing these studies, there were mostly outcomes were using the 6-minute walk test, where you walk back and forth down a hall and walk for 6 minutes, and we measure how far you go. And this is an early one for one of the first drugs that was approved, first oral drug, Bosentan. And you can see this was the primary pulmonary arterial hypertension in green, and comparing that to the ones in orange that were on the placebo, there's really a dramatic difference. But in the connective tissue disease pulmonary hypertension, they didn't have as much improvement, and the difference was mostly because the placebo, the sugar pill patients, had a deterioration. So once we started a new approach to analyzing these trials, and this was using a combined endpoint, where it was time to clinical problems, whether they had to be hospitalized because they had right heart failure, whether they had to start a more potent intravenous drug, or whether they had some other different parameters. This was really the first time that we saw that some of these drugs were now equally as good in scleroderma as they were in the idiopathic type. So this is a combination therapy of Ambrisentan and Tadalafi. One is an endothelin receptor antagonist, Ambrisentan, and Tadalafi is the PD5, is the drug that dilates the nitric oxide. And so here, this is the outcome for the patients that received it, and the patients who didn't do as well on this line were either taking Ambrisentan or Tadalafi alone. And there was a statistically significant, really much better outcome. This p-value only needs to be 0.05, and it was 0.0002. So there really was significant improvement. And the important thing is that it was very similar when they looked at it just for the scleroderma patients. And then the more recent study, this is a study of an oral prostacyclin, selexipag, and this is the subset of scleroderma patients. So the scleroderma patients did better. Their overall outcomes, they had less deterioration than those that were on the placebo, and that was significant. So this has been a really exciting time in pulmonary arterial hypertension. So the PHAROS study, which is our US study that had all these pulmonary hypertension patients with scleroderma, this is our most recent paper showing the outcome of that. There we go. So before we had any treatments, this was the survival. Almost nobody lived more than 2 years with this complication. And then many years ago, there was a pulmonary observational study called REVEAL, and also there were all pulmonary hypertension people. And this showed that the 5-year survival, only 40% of people were still alive. So our all-cause mortality for scleroderma with pulmonary hypertension at 5 years was 63%. But if you just looked at those who died from their pulmonary arterial hypertension, excluding that they happen to have cancer or heart disease or some other thing, or other scleroderma problems, their 5-year survival is now 76%. So we really have made dramatic effects as far as something that was really a deadly complication. Now it's a manageable, treatable complication. So there are still new exciting things happening. So for the first time, we have a phase 3, which is the definitive trial for a drug that's being specifically used in scleroderma pulmonary arterial hypertension. A drug called bardoxolone, which is a whole different pathway than the other drugs that we talked about. And their early phase 2 really had an exciting signal in scleroderma patients. And they're in the midst of trying to complete this study, and there will be an evening presentation tonight if you want to hear more about that study. There's also a very prolonged trial that's been going on for more than 10 years with a drug called Rituximab, and that's also specifically in scleroderma. So we're hoping to have the results of that coming soon. And there are other trials in pulmonary arterial hypertension as well. So it's really continues to be a very exciting time in this field. And now we have pulmonary fibrosis. So this is the other very, very serious lung disease. So if you remember the chest x-ray that I showed early on, the lungs were very dark and black, which was normal. Oh, it's a very sensitive computer here. And all this white area here that's in the lung, that's all scar tissue. So that's all pulmonary fibrosis. And this doesn't look quite like it should, but that's supposed to represent fibrosis. And what's happening, this is sort of a normal pathology of fibrosis. This is a normal lung cell. These are air cells here. And normally there's a connective tissue disease, and red blood cells are in here. So the air comes in through the lungs and then diffuses through this interstitium here, these cells here, into the red blood cells and gets into the bloodstream, and that's how you get your oxygen. When we have fibrosis, this thin line here gets much thicker with scar tissue in this interstitium. You still have the red blood cells, but you can imagine how getting the oxygen from the cells here has a much harder time diffusing through all this scar tissue to get into the red blood cells. And that's also why that diffusing capacity can go down in pulmonary fibrosis as well, because there's scar tissue in the lungs here as well as in the interstitium. So we've been looking at risk factors for this group of patients as well. And in contrast to pulmonary arterial hypertension, this is something that happens much earlier in the disease. The predominant problems happens really in the first couple of years of the disease. It's more common with patients with diffuse scleroderma, but it does happen with limited cutaneous scleroderma, although probably not in the anti-centromere patient. And so you can see how those antibodies are very helpful, because in this form of the disease, the anti-SCL70 is the antibody that really is the marker for severe fibrosis. And this nucleolar antibody is another antibody. We talked about it in pulmonary hypertension, but it also can be seen in patients with pulmonary fibrosis. So the antibody is really very helpful there. And again, African Americans have more common interstitial lung disease, and it does tend to be more severe. And my colleague, Dr. Silver, who you heard last night, has done a lot of work on trying to better understand why this fibrosis is much more severe. And there are some hints, and hopefully we'll find some either genetic or some other factor as to why that is. So the breathing test, this forced vital capacity that we talked about on the PFTs, that's much abnormal early in the disease, And then it's very important that we follow these pulmonary function tests, maybe even early in the disease, every 4 to 6 months. And then once we're sure that they're stable and not deteriorating, then maybe we could move to have them once a year or once every other year. And then having shortness of breath with exercise, again, exercise, and I'm not talking about running, I'm talking about walking fast, up a hill, upstairs, whatever. Having a cough, again, sometimes it's very subtle and not very obvious. And I've had many patients who have very abnormal pulmonary function tests and CT scans and really have trouble acknowledging that they have any breathing difficulties at all. So we talked about these forced vital capacity again. These are the tests that we measure, and this is the forced vital capacity, or FVC, is the one that we're using to determine whether our medications are helpful and improving or maybe just not having people deteriorate as fast. So this is another one of my studies from Pittsburgh, and we took a large 76 patients at the time that had severe fibrosis, and we looked back in our database and saw that these patients had pulmonary function tests at least twice in the first 4 years of their illness. And this is how we saw most of this is volume that they lose, and most of that volume is lost in the first 5 years of the disease. This is the first 5 years of the disease. We continue to see some loss as time goes on, but the biggest loss is in this first 5 years. And so that's where we've really been focusing. If we can stop this from developing and getting severe in this first 5 years of the illness, then maybe we can have it stay manageable. So one of the other tests that we do is the high-resolution CT scan. This is a fancy X-ray, but you don't need any contrast. You just lay there in this little donut-shaped thing, and then they get a very good look at whether you have scar tissue anywhere in your lung. And so I can finally say that now pulmonary fibrosis treatment, it's exciting times too. This has really been the big news in the last few years. So our treatment has been focused primarily on inflammation, which comes first and leads to scarring. And again, that scarring tends to be more common in the first 5 to 7 years of the disease. So that's really what we've been focusing on, trying to stop the inflammation and preventing fibrosis. But now we have new drugs that are trying to actually treat the fibrosis that's there. So we have 2 approaches to it. So more than 10 years ago, the scleroderma community in the US did the Scleroderma Lung Study 1. And this was what we call a double-blind, meaning nobody knew what they were getting. And everybody either got a placebo or Cytoxan or cyclophosphamide. And so it was a 1-year study, and then we followed them up for another year. And in that study, there was a significant difference in this forced vital capacity, mostly that the patients who got the placebo had deterioration, but the patients who received the Cytoxan had improved symptoms of shortness of breath, they had improved function, the HRCT was better, but unfortunately at the end of the 2 years, there was no difference. So if you only took the drug for 1 year and then didn't take anything the second year, you lost all the effectiveness of the drug. So then we did another study, the Scleroderma Lung Study 2, and this was finished relatively recently, and it was also double-blind. We didn't know who was getting it. And so we did the same 1 year of oral Cytoxan, and those patients then had another year of a placebo, and we compared this to 2 years of mycophenolate mofetil. This is an immunosuppressive drug that has been used in transplants in a lot of our diseases. And again, it was all people with early disease, with interstitial lung disease. And these patients that we had, they had a mean of only 2.5 years. Most of them had diffuse cutaneous disease. Their forced vital capacity was 66%, which, as you might think, that's significant lung disease. And then when we compared these two trials, these two treatments, actually both of the treatments had improvement. And so at the end of 1 year, comparing the Cytoxan versus the mycophenolate, or MMF, there really was no difference. There was a 3% improvement of the forced vital capacity, which is about equivalent to 112 milliliters. But again, symptoms were improved, well-being was improved, and in those with diffuse cutaneous disease, the skin was improved as well. But there was a lot of side effects of the Cytoxan, and many of the patients on Cytoxan had to withdraw. Almost half of them had to withdraw from the trial because of toxicity, low white counts, infections, whereas the patients on the mycophenolate seemed to tolerate that much better. So there's been other studies, there have been other trials and other drugs that have been helpful. We finished a drug called Tocilizumab, which was a drug that has been studied for skin involvement, for diffuse skin involvement. And although it didn't meet its endpoint for skin involvement, it looked like there was less deterioration of the lung disease, of the fibrosis, in that population of patients compared to the placebo. So that was quite exciting. But these were patients, although they were early in the disease, they were focused on skin. And so many of those patients did not have significant interstitial lung disease. So we don't really know what this drug is going to do if there's severe interstitial lung disease. And then there have been some other trials. There's been a couple of small trials with this Rituximab, which has been used in a lot of different diseases. There was one from Greece that had really significant improvement after 1 year in the forced vital capacity of 10%. There was another little larger study with 30 patients on Rituximab compared to 30 patients that were on IV Cytoxan. And at 6 months, they had significant improvement in the forced vital capacity versus in that patient population, as well as the skin score, the modified Rodnan skin score. So that, and it was tolerated well without severe toxicity. So this is exciting. We're waiting to hear what the follow-up information on that is. And so now we have what's been really the most exciting news in the world of scleroderma, the completion of a global study, 500 scleroderma patients with interstitial lung disease. This has been a monumental task to do, and it has been completed. It was a double-blind, 1-year study of this drug called Nintedanib, which is an antifibrotic. It's used for the treatment of idiopathic pulmonary fibrosis, a similar disease but not related to scleroderma. Half of those patients had background of having been on mycophenolate, and again, they were all patients that had early disease. Similar population, actually 576 patients, 52 years old, same as what our scleroderma lung studies, maybe a little bit slightly longer disease duration, 3.5 years. Again, mostly diffuse patients, but similar. The forced vital capacity wasn't quite as low, but very similar. And the exciting thing was that they had a statistical difference between the loss of the vital capacity in the Nintedanib patients compared to those who were on placebo. So this p-value of 0.04 is statistically significant, and really this is the first time that we've really had a drug that is going to be sent to the FDA, and hopefully we'll have to see what the FDA, may be the first official drug outside of our pulmonary hypertension drugs that will be officially approved for scleroderma interstitial lung disease. We won't know that until October. When we looked at some of the sub-analysis, we were particularly interested, since so many of our patients are on mycophenolate. There was still significant improvement compared to those that were on placebo, but it wasn't quite as impressive because they were already on the background mycophenolate. So there were a lot of side effects in this study. The drug caused a lot of GI problems with diarrhea, nausea, and vomiting. But the important thing is that it didn't require them to discontinue the study. They were able to lower the dose and yet still remain in the study. So at least it's a manageable side effect profile, and we'll have to see what happens in the next few months. And there are continuing to be new trials. So we're now in the midst of doing Scleroderma Lung Study 3, same group of investigators, and this is a similar design as the census trial, except that it's going to be up front. Everybody's going to get mycophenolate, and then they're either going to get the other antifibrotic called pirfenidone or a placebo. So it's a lot of pills, but we think it's the combination of the anti-inflammatory as well as the antifibrotic is really potentially going to have a big difference in the overall outcome of the disease. And then there's a large study using the Rituximab that I mentioned, which is going on in England, comparing Rituximab versus cyclophosphamide, and that we're hoping will be completed within the next year or so. And then there are other future studies going on. There's some very exciting studies that potentially from one of our colleagues, Dr. Figali Boswick, on our antifibrotic peptide. That's moving along, and hopefully we'll see that get into trials, as well as some other drugs that also have potential in interstitial lung disease. So again, what does this mean for you? Particularly if you have early disease, less than 7 years. Again, you need to have your PFTs, you need to have the CT scans, and if your doctor says that you need treatment because there's signs that you have potential progressive interstitial lung disease, we need to do aggressive treatment. If you are stable and the tests have been stable and they don't think it's progressive and don't think it needs to be treated, then you can relax a little bit and just have the test done every 1 to 2 years. Later, if you're someone that's had the disease 10 or 15 years and you've had interstitial disease that's sort of mild to moderate but doesn't seem to be progressive, there's a lot that you can do to prevent it from getting worse. We know that aspiration, we know that the reflux and the microaspiration when you're having the reflux is a contributor to worsening of pulmonary fibrosis. We know it can cause aspiration pneumonias, we can know all those things, but it also sort of silently can aggravate and make the fibrosis worse. So it's really important that you really take care of the reflux and don't eat before you go to bed and have your head at bed elevated and all those things. You have to prevent infection. You have to get your flu shots and your pneumonia shots and stay away from really sick people. You have to watch out to see whether you're developing low oxygens. And so oftentimes your doctors will be asking you to have a 6-minute walk. But a lot of the community pulmonary doctors still use the finger probes. And if you walk and you have scleroderma and Raynaud's, that finger probe, all the oxygen and blood leaves your fingers and you get a very low oxygen score. So you need to have that pulmonary function, or the pulmonary 6-minute walk with a forehead probe or an ear probe that isn't affected by the Raynaud's. And so we have to observe for developing pulmonary hypertension as well. So the low oxygen and the severe fibrosis can cause a secondary type of pulmonary hypertension. So using oxygen, preventing that is all very important. And the most important thing anybody can tell you to do is to exercise. Even if it doesn't change the pathology or the actual function, it will change the way you feel. It will be able to allow you to do more, to function better, to be more comfortable with your activity level. So in summary, lung disease is the most serious complication of scleroderma. Pulmonary arterial hypertension occurs later in the disease, needs to be screened for in all long-standing patients, and there's lots of treatments and continued new studies are available. And pulmonary fibrosis needs to be identified early, treated early and aggressively. Mycophenolate is our go-to medication at the moment, but there are new trials suggesting additional drugs may be helpful, additive, and it's really a very exciting time in this field. Thank you.